Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.
You're listening to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. With us is Dr. Robert Popovian in Washington, D.C. He's a pharmacist, an economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation.
And joining me, as always, is my good friend, Ben Blanc, from the heartland of the United States, Indianapolis, Indiana. Ben is our Director of Digital Production and Engagement at GHLF. Well, Ben, we're at an inflection point. You and I have been talking about PBMs and PBM reform for the last several years. And I have to say, we have seen more movement and activity on PBM reform in the last 3 months than we had seen in the past 20 years. And it'll be interesting to see how this thing evolves, but there's a lot of activity that we're going to discuss today with our guest.
Yeah, and for a long time, PBMs were this technical, almost niche topic. Now, we're seeing FTC settlements, congressional hearings, and employers asking tougher questions.
Absolutely, Ben. So transparency is the key, and that's what we've talked about on this podcast on multiple occasions. Without transparency and data information that is available for plan sponsors, specifically employers and the government and patients and providers, we will make that policy decision. So starting with these things that we're doing, whether it's on the legislative level or regulatory level, we are going to see more transparency in the market.
And that's exactly why today's conversation is so important. We're diving in one of the most complex and consequential issues in U.S. healthcare right now, pharmacy benefit managers. We'll call them PBMs. Over the past few months, we've seen unprecedented scrutiny from the FTC and growing momentum at both the federal and state levels to increase oversight of PBM practices. For patients, employers, and health systems, these developments could shape how prescription drugs are priced, reimbursed, and accessed for years to come. So let's get to it. To help ground this conversation, we're joined by Robert Schenk, who brings a rare dual perspective to this issue. Robert is the Network Director of Pharmacy Strategy and Operations at Hackensack Meridian Health, one of the largest health systems in the country. He's also deeply involved in PBM oversight and forensic claims analysis through pharmacy benefit forensics, where his work focuses on uncovering fraud, waste, and abuse, and helping employers and health systems better understand how their pharmacy benefits are actually performing. Robert, you're someone who lives at the intersection of health systems, plan sponsors, and PBM accountability, which makes your perspective especially valuable right now. So thank you so much for joining us on the show.
Thanks for having me. And feel free to call me Bob, especially since we have two Roberts on the show today.
Will do. All right, so before we dive into the policy and regulatory changes, it's helpful for our listeners to understand the vantage point you bring to this conversation. So Bob, let's start with you. You wear a couple of important hats. First, as Network Director of Pharmacy Strategy and Operations at Hackensack Meridian Health, and second, through your work with pharmacy benefit forensics. Can you walk our listeners through what those roles involve and how they intersect with your day-to-day work?
I'm happy to do so. It's been a long, strange trip to get to where I am. As you can imagine, over the last 20 plus years of pharmacy benefits in this country. But both roles definitely overlap. Much of what I do as the Network Director of Pharmacy Strategy helps inform my work in PBM forensic analysis. Both jobs stem from my underlying desire to help others, my entrepreneurial personality, and mathematical curiosity. So everything I've done in my pharmacy career, it seems, from working at hospital pharmacies, owning 2 independent community pharmacies, consulting in nursing homes, and then managing the employee pharmacies for Hackensack Meridian, has kind of led me to where I am. You asked about how they intersect, and I hope you don't mind. I just want to go back just a little bit to give some perspective, but I want to speak about my time as an independent pharmacy owner, because that's kind of where this interest began, and it kind of led to the intersection. I opened my first independent community pharmacy in 1986, and then a second one in 2000. And I sold them both in 2003. And a large reason for getting out of that business was the PBM reimbursements. Even back then, we were getting killed by PBMs. And unfortunately, I can remember the very first time as a pharmacy owner that I got reimbursed by a PBM less than my acquisition cost from the drug. And that was my first deep dive into analytics and trying to understand how or even if that was possible back in the early 2000s, only to find out that unfortunately it was possible. We did have a negative margin on that particular prescription, and I started to see more and more, and I started to think, well, this is not a good long-term viable business possibly. And so I sold the businesses and I went into clinical consulting, which led me to Meridian Health, which then became Hackensack Meridian. Once I got there, I was offered the ability to manage 2 of their employee pharmacies. And so that's where I really started to get deep into the employer side of PBMs. The human resource folks were complaining to me that their PBM wasn't saving the money that they had promised. And so I did a simple thing and I said, well, can I see the claims? What are you paying? And nobody had ever asked them for that level of information before. They were used to paying just summary invoices every month. When I finally did get to see like the detailed claims of what they were paying, it struck me that it wasn't just the retail pharmacies that were getting fleeced by the PBMs, but the employers as well. And I basically, over the next couple of years, I dedicated myself as part of my pharmacy manager job to also assist with the human resource, with the benefits side, and kind of use my knowledge and experience to help them better manage their business and their costs. And as part of that, I came across spread pricing, and I shared that with, it was actually in a Fortune magazine article in 2016, written by a phenomenal investigative reporter, Catherine Eben, and it was titled Painful Prescription, and it kind of explained the Hackensack Meridian's journey through the PBM maze and this whole concept of spread pricing. And so once I got kind of interested in that, I started to really go into more depth and looking at fraud, waste, and abuse and finding just unbelievable examples of fraud and that weren't being picked up by our PBM, claims that were being paid. One of my favorites is when I found that our PBM was paying claims for a drug called Azesco, which was a prenatal vitamin. So not bad, except these were for men. I was finding about 35 men that were getting coverage for this prenatal vitamin that, by the way, cost $1,000 a month. So just think how quickly a simple little vitamin claim goes unnoticed by the PBM. 30 or 40 people take it, and all of a sudden it's $500,000 impact on your annual spend. So this is where I realized that there was maybe an opportunity to take this idea into a business, and kind of that's where pharmacy benefit forensics was formed. And I started a website and I tried to inform other people about these things that I was finding and share them with the hopes that they could look into their claims and get their PBMs to fix them.
Well, thanks, Bob, for sharing all this. Thanks for sharing also the very telling example of the experience you had with your pharmacy, which led you to where you are today. That dual perspective certainly highlights how complex this system can be, which brings us to what's been happening at the policy level. So, Robert, the last few months have been incredibly active in terms of PBM regulation and oversight. So, for listeners who may not be tracking every development like you are, can you give us a quick lay of the land and what's happened since late 2025 and why does it matter?
Sure, happy to. It started in the latter part of 2025, actually. And if you go back, that's when our largest state in the union, California, legislation passed that reform. It was a PBM reform legislation that actually was vetoed at least once by the governor of California, Gavin Newsom, previously in the previous years. And finally, he signed it into law. It was very comprehensive. It's probably the most comprehensive PBM legislative reform for a state level. It did things like it prohibited PBMs from steering patients moving forward. It made sure that there are flat fees involved instead of fees based on retail price of medicines as a percentage. It created an environment that there will be no spread pricing, fair reimbursement for independent pharmacies and community pharmacies. So there was a lot of things that happened. Then towards the end in December, the House released a draft legislation. It was a bipartisan legislation by various members of the House. We were fortunate enough in Global Healthy Living Foundation, they asked us to actually provide a quote. I was quoted in the press release that was put out by Congressman Jake Auchincloss. So that came about. Then earlier in January, there was a lot of discussions about budget reconciliation that needed to happen, and PBM reform language was included in that. It was included in the previous one too, but unfortunately, because of a temper tantrum by Elon Musk, it was pulled out at the last minute. And finally, this made it into the budget reconciliation data or information into the language. And that came into fruition. Again, similar things, transparency, no spread pricing, actual reimbursement fees that are more flat. And then the bombshell really dropped last week. And this is something I want to hear from Bob's opinion, is the FTC sort of settlement with Express Scripts is the second largest PBM in the country. That came about as a settlement that happened between FTC and Express Scripts that made a slew of changes that the company agreed to, or changes that the company agreed to do. There's going to be some enforcement. They have to do some reporting back to the FTC and the government. So I want to hear Bob's opinion on that, because that's the latest iteration that has not only somewhat changed the dynamics, but now you have enforcement. And it's a federal agency that's going to be basically overlooking a PBM's business activity. Now, let's start with Bob and his opinion on that.
Robert, I think you started off your introductory part talking about data, and that's where I think you really are correct. And we recognized the importance of access to data years ago at Hackensack Meridian and through our benefits coalition, and we fought really hard to get access to it. Now, it helps that we have 3 million covered lives in our coalition, and we're probably one of the largest groups that any of the big 3 PBMs deal with, for sure. And that gives you leverage to get a lot of that data. So a lot of the data in the FTC settlement is data that we already have. But there are a couple of new things along the way. The FTC settlement and the new PBM regs last week, I think, will help other employers get access to the data that we've had for a long time. Hopefully, they're going to know what to do with it, but it's critical to have it to make change, right? So even though we see it, we'll start getting some additional new data this year that we negotiated last year. Some of that is in the FTC settlement. One of the things that I'm looking forward to is paid claims data by pharmacy. And so why is that important? Because up until now, other than that painful prescription article that I talked about, there's not too many people that have seen both sides of pharmacy claim adjudication. If you're an employer, you see the employer side. If you're a pharmacy, you see the pharmacy side, right? But this legislation will allow employers to see the pharmacy side. PBMs never wanted to relinquish that data, and because they said it was proprietary contractual information. That data shows what levels they reimburse the pharmacies at. And so that data would definitely have access to it years ago, most likely would have stopped spread pricing in its tracks if payers got to see what the PBMs were reimbursing pharmacies and charging them, right? It also would have highlighted what PBMs were paying their own pharmacies. And as has come out over the years, there are many instances where the big PBMs have paid their own pharmacies, whether they're mail order pharmacies or their own specialty pharmacies, or even their own retail pharmacies, if they're in that business, at much higher levels than they pay independent pharmacies, for example. This year, we're also going to see rebate data from the PBMs of what they receive from pharma. And we've received that data for many years, but it was always on a much higher level. It was at the manufacturer level. We might see a data report that says there was X dollars from Novo Nordisk for so many claims in whatever time period. This year, we're going to see the rebate data down to the NDC level. So for people that don't know what NDC is, the National Drug Code will pinpoint a rebate to a specific drug at a specific point in time. That's really great information to have as we fight to push back on PBMs and releasing that data and what level that rebate is being paid at. We've always had quarterly reports. Some of the things in the FTC settlement, like reporting, we've always had quarterly reports, annual drug reporting, and we've always insisted on actually daily access to PBM reporting tools where we can go in and get our own reports. We've also had access to fees, I think fees is going to be important in the future, more so than now, because I think PBMs are going to be more reliant on fees. But we've had transparency on fees in our program, whether it's the GPO and what their fees are, or the consultants and what their fees are. We see that. And we understand what that is, and we agree to pay it, obviously, because we think we're getting value for those fees. I think an additional insight would be for consultants, especially, to disclose any fees they receive from PBMs outside of the individual plan. I remember at least more than 10 years ago, there's a great legal consultant, Linda Kahn, who works out of New Jersey, I believe, who always preached about getting consultants to sign a no conflict of interest statement at the time that you engage them. And I thought that was always a great idea. And of course, whenever I've had the chance to ask consultants to sign that, they always get a little antsy. And so that's always led me to believe, like her, that these consultants may be getting compensation outside of the plan directly, but like via the PBMs.
Thanks, Bob. So you mentioned the importance of access to data, transparency on all of those fees, but it seems like transparency alone doesn't always equal accountability. So, Robert, circling back to the settlement, it applies specifically to Express Scripts. In your view, what important issues are still left unaddressed? And if you were advising policymakers, how could this agreement be strengthened or expanded to better protect patients and plan sponsors?
Ben, you're absolutely right. So this only applies to Express Scripts. It is up to the policymakers now to take this and almost force PCMA, which is the trade organization that represents PBMs, to almost adopt it as a standard of practice, right, for all PBMs that are members of PCMA, and becomes like a nationwide policy for all PBMs functioning in the marketplace. The second thing that Bob alluded to, a couple of things that were left out, which I think we need to go back and strengthen. One is steering. The FTC settlement did not address steering of patients to Express Script-owned specialty pharmacies. Why is this important? The reason being is that specialty medicines, even though, again, we've had this discussion on this podcast, there is no definition of specialty medicine. If you go open the FDA book, FDA doesn't recognize any drug as a specialty drug. It was basically created through the Medicare Modernization Act in the mid-2000s. When they instituted Part D, they created a category of drugs based on price, and they called it specialty medicines. All of a sudden, in the last, I would say, decade, all of these specialty pharmacies that used to be independently owned have been purchased by PBMs. Now, about 80% of dispensing of these specialty pharmacies come from 3 PBMs. It's Express Scripts, it's Optum Rx, and it's CVS Caremark. So what they're doing now, because that's where the money is, right? That's where Bob alluded to. That's where the rebates are. Those are the drugs that carry the high rebate dollars, and they carry the high fees and everything else because it's based on retail prices. That money funnels through the specialty pharmacies. And in fact, if you look at some of the older research done, even by the Schaefer Institute, what they tell you is that the money aspect of who makes money in the PBM business model is the specialty pharmacy. But what they've failed to recognize is that specialty pharmacies are owned by PBMs. So that's one of the misses that I think happened with the FTC settlement, that whole issue of specialty pharmacy patient steering was not addressed. The other thing that is important also to note with regards to specialty pharmacy and PBMs and so on is that not only that's where the money is and that's where the funneling of the PBM rebates and everything goes through, but also that they had a role. Even the FTC recognized it in their reports that they had a role, and Bob talked about it, about inflating reimbursements for themselves. So if you're not prohibiting steering, not only are you basically hiding money in another way that's not going to be transparent to a lot of people because the money is then going to flow through these specialty pharmacies, but as the FTC report found last year, in 2024, what it found is that if patients end up going to a specialty pharmacy that is PBM owned, the reimbursement is higher, significantly higher than what they would pay independent pharmacies in the marketplace, but then also that they utilize those resources, additional resources and higher reimbursement to drive out even more competition from the market. So those are the big misses that I saw. The other thing that I think the FTC didn't recognize and do a good job is who's a plan sponsor. They talked about this information should be shared with the plan sponsor. Well, the plan sponsor in majority of the cases today are the insurance companies that own the PBMs. It would have been ideal if we define who is a plan sponsor, which is an employer or the government or a patient or an individual that buys the insurance for themselves. So those are some of the misses. They can be fixed, but in my opinion, it's a very big step forward, and it's a recognition that FTC needs to regulate this business environment.
So we're talking about one settlement. So beyond this single settlement, there's clearly a broader reform conversation underway. So Bob, let's go back to you. Beyond the FTC agreement, what additional regulatory or policy changes would be most helpful for plan sponsors like Meridian? And where do you see the biggest opportunities for meaningful reforms?
I think there are two huge regulatory areas of opportunity, one of which Robert has talked about with what I call structural change. And the other is meaning PBMs owning their own pharmacies. And I'll speak to that in a minute. But I think the biggest one, the opportunity for regulatory would be rebates. And the rebates, I think, and I've been personally involved in multiple RFPs over the years, setting aside the fact that there can be operational differences between competing PBMs. In reality, the finalists, the winning bidders in those RFPs, always comes down to the financials, right? It's the bottom line, the CFOs, the HR benefits people that are trying to control their costs. So that's expected. Obviously, they have a fiduciary responsibility to manage their spend. But the main differentiator that I see in those different PBM proposals is always in the rebates, the significant differentiator. And there's generally a standardized kind of template that the consultants all use through these RFP processes, and they compare the discount rates that each PBM is offering as part of their bid. In other words, the employer will pay no less than average wholesale price minus 20%, and the other PBM might be average wholesale price minus 19.5%. The third one might be minus 20.5%. They're always within a percent of each other, whether it's the small PBMs or the large PBMs. And so there's not a whole lot of wiggle room there. So really the only place that leaves them for wiggle room is rebates. And specifically, when you're dealing with at least the big three PBMs, they have very deep pockets, right? So the part of that matrix I was talking about comes down to comparing one PBM's guaranteed minimum rebates to another PBM's guaranteed minimum rebates. And the fact that the big threes have those deep pockets means potentially they could overestimate rebates if they really wanted to get somebody's business, because when the bottom line is so much lower because of those guaranteed rebates, they can get their foot in the door of business that a smaller PBM could not. And so what I'm suggesting is if we can get to a system where it's lowest net cost and there are no rebates, that would go a long way towards leveling the playing field. Then you might say, well, that's really pie in the sky, like it's kind of Pollyanna. But I think what I can point to is about 7 years ago, when Alex Azar was the head of the FTC under the first Trump administration. That was actually a proposal. He proposed that regulation. At the time, I was so excited, many pharmacies were, that could you imagine in a world where no rebates? Well, obviously, and Robert probably knows more of the reasons behind it. All I know is that it never came to pass, obviously because of the politics behind that, whether it was the PBMs or pharma or whoever influenced the voting or that regulatory process. It didn't happen. But if you ask me what a opportunity for regulatory, it would be rebates. And the second would be, my second favorite area that Robert talked about is PBMs owning their own pharmacies. And so they can own their own retail, specialty, and mail order pharmacies. And that's when I was talking about structural change, that's kind of the regulation I'm talking about there. I'm starting to hear that. I think we've heard Mark Cuban talk about that. There are states like Arkansas that have already passed legislation about that. I think it's currently being contested in court. Other states, Arizona, California, trying to do that individually. And 2 months ago, or back in December, I had an opportunity to be on the New Jersey Governor's Interdisciplinary Transition Council. My area was healthcare affordability, and that was one of the specific items that I requested that they look into legislating on, and that would be prohibiting PBMs from owning those vertically integrated pharmacies. Caution, I don't want to go back to the days, and Robert probably remembers, before the insurance companies owned the PBMs. They were owned, when I started, by pharma. So Eli Lilly owned PCS out in Arizona, and Merck owned Medco, became paid prescriptions, right? I don't think we want to go turn the clock back that far, and we need to trust that if we do get rid of that, pharma will play fair, whether it's, I think there's more downside pressure on their pricing nowadays with most favored nation and IRA and all that stuff, but I don't want to open the whole market up to pharma either without some controls.
But let me reflect on something Bob said. Number one, net price contracting is something we've talked about, right? So people don't understand. When you go to a net price contracting, you also get rid of not only rebates, but also you get rid of fees and everything else that is attached to it. Because as soon as you get rid of rebate contracting, fees go away. A lot of fees. You still have data sharing agreements and things like that. That's fine. But a lot of other things go away. And why is net price contracting important is because of these rebate aggregators, these companies that exist now. So everybody's getting the same rebate. The difference is really the other parts that the bigger PBMs can bring to the table compared to a smaller PBM. But having said that, net price contracting currently exists. The largest state in the country is California. The largest insurer in California is Kaiser Permanente. Kaiser Permanente uses net price contracting without rebates or fees or anything else and passes on all of the value and savings directly to the patients. So it can be done. Now, Bob is absolutely right. In the first Trump administration, somehow this administration, current one, has amnesia, right? Doesn't want to remember anything good that came out of the first Trump administration, which was the elimination of rebate contracting within Medicare Part D. And that would have fixed a lot of the ills that we have still ongoing for the last 8 years or 6 years since that thing was defeated. And the defeat was primarily a political issue. And the reason it was political is because there's this misunderstanding within the government, especially within CMS, that they look at pharma companies as foes, as people they have to like keep an eye on and watch out for any price increases and everything else. They look at PBMs as partners. And that mentality has been instituted since the inception of Part D, because without the PBMs, Part D wouldn't have come into fruition. And so within CMS, historically, there's been this idea that PBMs are a partner to us rather than a foe. And I think that the partners who are the PBMs have taken advantage of that situation.
Thank you, Robert. And as pressure builds from multiple directions, the industry is being forced to respond. So, Robert, as Congress, the FTC, and the state governments push new rules alongside major policies like the IRA and other pricing initiatives, how have PBMs and the pharmaceutical industry responded so far? And looking ahead, what do you see as the likely consequences for PBM profitability, state budgets, and employer rebate revenue?
So, Ben, you raised something really interesting. So, when we talk initially on this podcast, we talked a lot about the FTC and the regulations and the legislation that was introduced, whether it was in the House, the California legislation, so on and so forth. Those are all important. But there are other things going on in the market that are putting pressure on rethinking the drug pricing environment. And that's one you alluded to, is the Inflation Reduction Act, the Most Favored Nation Act that is coming to play. These are also areas that's putting onus on the pharma companies now to really rethink their pricing models. So what is the consequences of things like IRA, for example, right? So IRA is a very interesting dilemma for pharma, but as much of a dilemma for PBMs. Because if you reduce the wholesale average cost of a drug, guess what's going to happen to the PBM margins? They're also going to get reduced because they're going to get less rebates, they're going to get less fees, so on and so forth. What we've seen with the IRA so far, the reaction from pharma has been that, and this was also illustrated last week, is that some of those IRA drugs that were chosen as the first set of drugs, the pharma companies have actually taken, not only they've given these huge discounts to the CMS for Part D through the negotiation, but they've taken huge reductions in their wholesale acquisition cost prices. So Eliquis, for example, took a 43% price reduction. What is that going to do? Eliquis is a commonly used anticoagulant. That is going to put pressure on PBM revenue, and in turn is going to put pressure on whether it's rebates, whether it's fees, and also how much money they pass back to employers and plan sponsors and the government itself. So this whole dynamic of changing, whether it's through legislation or voluntary changes because of external pressures like Inflation Reduction Act, is really going to put a bullseye on how we price medicines and how the pricing is going to shift. Look, when the three manufacturers of insulin about 2 years ago, maybe 3 years ago now, voluntarily took a price decrease where they reduced their prices of their insulins, the people who lost money in that were the PBMs. The manufacturers were still making money because the net price they kept it at was actually higher than the net price that they were getting back after all the rebates and fees and everything else they were giving the PBMs. So the only loser was the manufacturers. And in fact, what I heard, I got contacted by a prominent newspaper reporter who asked me, so I don't understand. There's been this huge reduction in the price of insulin on some of the prices of these insulin, commonly used insulins. And what we're hearing from the clinics is that some of the clinics, for example, that get paid on margins of the difference in price are switching patients to more expensive medicines. Why is that? And I said, because it's a margin play. Everything has become in pharma a margin play. And as soon as your margins start shrinking, you're going to look at somewhere else to make money. And that's another thing, Ben. PBMs are not going to step away from this revenue loss, right? So they're not going to go, okay, yeah, we're going to make less money because of IRA, because of voluntary WAC reductions, because of all this legislation that's being passed, that we are mandated to do this and that and everything else. They're going to find a different way to make money. And in fact, by the time we're done with this podcast, they will come up with 2 or 3 other ways to make money because they're not going to walk away from profitability. It's not going to happen. It's the private sector. I've never seen a PBM make less money one year compared to the previous year. So they're going to figure out another way to make money. In our case, Ben, we work for a patient organization. Our biggest concern is this going to be borne by patients with regards to their out-of-pocket costs? And we've talked about this pioneer research. We've done some work on the IRA drugs, the first set of 10. And what we've seen year over year in the first 3 quarters of 2025 compared to first 3 quarters of 2024, PBMs are actually charging more money out of pocket for those drugs from seniors compared to 2024. Now, we're going to get the full 2025 data soon. We'll come back and talk about that in a future podcast. But right now, the trend is one of the ways that they're going to make the difference in profitability is on the back of patients.
And Bob, you've just heard Robert's take on how the industry is reacting. So from where you sit as a plan sponsor, what resonates with you in that assessment? And where might you see things differently based on what you're experiencing on the ground?
So I think Robert obviously is the expert on all those outcomes, and he's really got his finger on it. I think probably the best I can do is speak from the employer or the sponsor perspective and how those changes may affect our overall benefit costs, which of course then flow into what we as employees pay for premiums in a self-funded plan, right? So it's kind of critical that we maintain our costs from escalating. But I think one of the things we will see, I don't think it's a bad thing for us, is the rebate revenues will definitely drop. As you guys were talking about the IRA, the MFN, I think an interesting outcome of that is that it's pushed pharma to embrace or at least to explore more these direct-to-consumer models and the net pricing in which they're not really harmed because at the end of the day, they're selling their drug for whatever it is after rebates in the commercial market. And actually, I think they like it. I think they enjoy not having the middleman if they can't. I think, as I mentioned before, the transparency and the NDC level rebate reporting is going to also impact the market. If the FTC, one of the things they talked about in the settlement was the establishment of the standard model. And so if that standard model does catch on, PBMs might be forced to live with no rebates. And obviously then they're going to want to increase their fees. We saw that already this year in the latest RFP that we had as they were moving to more fee increases that they hadn't in previous years. So not speaking necessarily for my employer, but personally, I don't really see a negative in the lowest net price model. I think it could be a wash, hopefully, and result in the same bottom line benefit costs, which then we can set about the real task as pharmacists and maybe as pharmacy benefit managers that want to be in that space of managing spend by looking at addressing formulary and what drugs are on the formulary and utilization and smarter utilization. So that's kind of what I'm looking forward to. The only other concern I think I want to speak to in the FTC settlement was Section 5B. says that the standard plan will not provide a guarantee to the plan sponsor of a predetermined amount of compensation, including rebates. So that leads me to believe they want to get away from those guaranteed rebate minimums that I was talking about before. And if we're going to get away from rebates, that's fine. But I fear that the PBMs may use that as a means to go around the standard model, the standard plan that the FTC is recommending. Because if one plan they don't show any rebates and the other one they are going to show rebates, it's going to, with the aid of consultants, potentially drive people away from the standard plan. And that would be a shame.
Bob, thank you so much for joining us on the podcast, for sharing your perspective on the ground. We really appreciate it.
Thank you so much for inviting me. I really enjoyed this.
My main takeaway is that PBM reform isn't just about pricing. It's about transparency, it's about accountability, about aligning incentives so that employers, health systems, and patients actually benefit from the pharmacy dollars being spent on their behalf. So while recent regulatory actions are an important step forward, real reform will require sustained oversight and, like Bob mentioned, better data access for plan sponsors. And they'll also require policies that prioritize patient access over non-transparent, rebate-driven business models. But I'm not the expert, so Robert, take it away. You have the last word.
It's a great summary, Ben, but I have to say, this type of activity, whether it's through FTC, through legislation, through regulatory changes, it's going to force not only pharma companies that are looking into changing their pricing models, whether PBMs do it differently, but also, as Bob mentioned, the reliance on rebates and rebate guarantees by employers. And this is going to change the way they have to do. Now, put aside what Bob does for Meridian, I think they're doing calculus. Most employers are not. They're in basic math right now. So they're going to have to come up to speed exactly how they're going to survive without rebate guarantees and all these things, and have to hire people like Bob to come and work for them to be able to maneuver them through a PBM formulary design that doesn't chase the guaranteed rebate dollars, but instead it's a value proposition for its members or its employers or its patients. That's going to be one thing that's going to happen for sure. The other thing that's going to happen, and this is what happens when you start poking the bear. As you see more and more drug prices come down, they become more of a net price issue. Legislators are going to still have to delve and focus on healthcare costs in the United States. So the focus is then going to shift into hospitals and providers, how much they cost. Because let me tell you, as much as you want to slice and dice drug costs from the healthcare system, they make up maybe 10 to 15% of the dollars spent. So let's assume that we've taken care of that 10 to 15%. What are you going to do with the other 85%? That's when you have to start opening up the charge masters for hospitals, and you have to start looking at salaries of healthcare professionals and everything else that we're paying, because that's where the biggest savings are going to occur. So again, these changes are great. They need to happen, but it's going to force an alternative environment where employers have to function differently. But also, what does the government do next? Because they can't take any more money out of pharma. Are they going to get in front of the healthcare cost issue as a global issue, as an overall healthcare cost issue that they're basically been ignoring because their focus has been pharma for a long time?
Well, thanks for breaking all that down for us, Robert. I think that was some very valuable information for our listeners. And Robert, I know this is only our second episode of the season, but it is my last episode with you. I'm heading off on a new adventure, and before we close, I just wanted to take a moment to say thank you. So to our listeners, thank you for showing up week after week and for engaging with us, for caring about these complex issues that truly matter. Your curiosity and commitment are what make this podcast possible. And Robert, thank you for being an exceptional co-host. I have learned so much from you over the years. It's been an honor and a real pleasure working alongside you.
I can't thank you enough for being a partner in this. You're an exceptional friend, first and foremost, a knowledgeable co-host, and someone that I have come to rely on significantly in moving this podcast along over the last 7 seasons and 2 episodes, right? So the podcast will continue. It will not be the same without you, but we have a voice that we bring to patients and to providers and to everybody else who's interested in the policy discussions. And hopefully we'll have guests like Bob come back and help us out, like deliver first-rate podcasts to our audience in the future.
Well, thank you, Robert. And that's it for us. Don't forget to subscribe to our podcast on Apple Podcasts, Spotify, or wherever you might be listening so you never miss an episode. And if you have a second, help spread the word by rating our podcast, writing a positive review, and sharing with your family and friends. It'll help more people like you find us.
And as always, if you have any questions, comments, thoughts, suggestions, please reach out to us at podcasts@ghlf.org. You know what? Bob and I met about 2 weeks ago at another sort of event we were both speaking at, and I asked him, and he cordially agreed to come on and be part of our podcast. But if you have good ideas and commentary and you want to be on the podcast, please reach out to us directly, again, at podcasts@ghlf.org.
And you might be featured on the show. And before you go, make sure to take a listen to some of our other great podcasts on the GHLF Podcast Network. You can find all of GHLF's podcasts at ghlf.org/listen. He's Dr. Robert Popovian.
And he's Ben Blanc. We'll see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.